I'd like to call this meeting to order. Welcome all of you here this evening. I'd like to invite you all to stand and join me in the pledge of allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Lovely. Notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury Avenue, Fremont, and is also accessible by Zoom. I ask that you mute your systems until such time as you need to speak. We are recording tonight's regular session of the board. This evening, that recording will be posted on our website for future viewing. Cheryl, if you take the roll for us, please.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace. Director Yee.
Present.
And Director Epen.
Present.
We'll now move to oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement, not to exceed 3 minutes, on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. We have with us this evening several who have given us speaker cards. I have 4 here that we invite you to come up and speak. Is there an order you'd like to speak in? Pardon?
No, whatever was given, that's fine.
All right, then first we'll hear from Jessica Ula. If you could, right, this is, come up here and do I have to listen?
And there are 3 minutes. Yes, you'll have 3 minutes, and I'll tell you when 30 seconds is left. 3 minutes. Okay.
All right, so we just came from SEIU union negotiations right now, and we find it very, very, very appalling that we were given a 9.5% wage increase across the board. And the reason why I'm saying that is because we have skilled professionals such as scrub techs, rehab aides, assistants, we have phlebotomists, we have respiratory aides that cannot even afford to live in the same city that they work in, even with 9.5%. So to us, we find that appalling. To us, the way we feel is that you don't appreciate us. You disregard us. You see us as the bottom feeders. You guys don't take us seriously enough, even though we are trained professionals. So therefore, we feel that this is appalling. This is concerning that you guys hold yourselves high like Kaiser standards, but which you are paying us Walmart standards. This isn't even a reality for some of these people that are struggling moms, single parents, or even a 2-parent income household that are struggling to pay for college, not just for themselves, but for their own children. So in this sense, to us, it feels like you guys aren't taking us seriously. It feels like you guys don't regard us as the same standards as you do your nurses and your doctors. So to us, this is very concerning, and we don't appreciate the disrespect that we have been shown, and to sit here and also want to raise for a family of 4 or family of 6 from our $29.95 bi-weekly pay that we pay for our insurance. You guys want to raise it to $197? We don't have nurses' wages. We don't get paid big bucks. So for you guys to be sitting here and putting that standard on us is ridiculous. And we find it very appalling and troublesome that you guys would even put that out there. So on behalf of SEIU and my members, my people, we find it very appalling, and we do not appreciate your disrespect. And we hope that you guys can come to the table with an even better offer and actually make it a livable wage, instead of my scrub tech, my phlebotomist, my OR support techs having to live all the way in Oakland or even Patterson just to make a wage. This is ridiculous, and I beg you,
30 seconds.
beg you to please reconsider. Thank you so much.
Thank you, Joe. I now have another speaker card for Donna Knapp.
to expect. Good afternoon, folks. Thanks for having us here. I'm Donna Mack. I am the union representative for SAU-USW that workers here at Washington Hospital. I've been in healthcare for the last maybe 35 years, and I started as a healthcare worker. For 20 years, I worked as a CNA in the East Coast, in New York City. And I came to California on an assignment, and I got to stay here. So, welcome, glad to be here. But I just want to say that healthcare matters to me. That's my passion. And then I decided to work with the union. And my job here today is not even about the union, it's about people and the members and the patients that's here at Washington Hospital. We've been at bargaining since April. We have got you some articles in the contract yearly, and we know when it comes to wages and benefits, this was going to be an issue. Today, we were presented with an economic package, and we feel like that is worrisome. That is not what we think that we are worth as healthcare workers. And I know the board has a big impact in the final analysis of what is done in the ending, so we are here to say, be mindful, listen here, because we are healthcare workers, but we are also fighters. And I instill respect, humility, but I expect results. So whatever it takes, that's a negotiating table. When we get to the final numbers, we want to let this board know that we would be very, very serious about it. Whatever the team decides, whatever that number is, whatever the package is, there would be no, that would be it. I'm prepared to say, I personally have a good relationship here at Washington Hospital with the management team, I must say that. But I'm also a fighter, and I'm here as the leader or working alongside the team where we pull that trigger. That would be, so just keep that in mind, and whatever it takes to get that where we're gonna be, that's what it will take, guys. And so we ask that you keep that in mind. We will keep coming talking to you, share our concerns until we get to where we need to be. Thank you.
Thank you.
Thank you, Donna. I now have another card for Nicole. I apologize, I'm not sure how you pronounce your last name.
Leva.
Leva? So Nicole Leva, thank you.
Hello, I'm Nicole Leva. I'm a surgical tech here at Washington Hospital. I've worked here almost 30 years, and I love this hospital, and I've always been proud to work here. It's that this Bay Area, the price of living is skyrocketed, and to live here is just harder and harder. And with our wages, I'm a widow. I was widowed 4 years ago, and I'm trying to take care of my family on my own, and I have to work 2 jobs, and I barely make it. I do get Social Security, and then I don't get it after next year, and I don't know what to do. And down the street, they make more money. And there's times where that seems attractive. Oh, I can go to the surgery center down the street because I see our contract isn't gonna bring us up to the same level or what we need to get by in this area. But I don't want to lose my retirement here. You know, there's so many things to think about with the, they want to raise our medical. The rate they want to give us, that's just going to pay for our medical. So that alone doesn't really equal out. So I'm just here trying to help fight for us to get what we need to continue to work here and do the standard of care that we give and live in this area. I have to say, and I thank you.
Thank you.
Thank you, Nicole.
Thank you, Nicole. I have one last speaker card for Janelle Shaw.
My name is Janelle Shaw. I'm a surgical tech in the main OR. I've worked here since 2008. Through our past 3 negotiations, we've had very low raises, 1% every year, which does not even count for the cost of living. I know I personally and all my fellow coworkers provide a service to this hospital that increases our incomes and our level of care to the patients around us and to the community. And I don't think that we are representative for what we provide to the patients and to the physicians here. We work long hours, we cover multiple shifts. We are basically breaking our backs in order to prepare others. And today, like she said, we had our negotiations, and what they offer to us is not what we expected, not what we feel that we deserve. The cost of living, like everyone else has said, has gone up. I take call that is required of me, but I have to be here within 30 minutes, but I can't live within 30 minutes. Sometimes, in the past, I had to stay in hotels in order to be close by. And I don't think that that's fair. I think that I should be able to live in the community that I serve. I don't have any children, so of course, like the medical benefits, I don't have to pay for. But with this new plan, I'll be paying almost $100 biweekly. And again, with the percentage that's being offered, it's just going to be taken from me with benefits, as well as the gas that I pay to get here every day. So I just want to say that I'm not just an employee member, I'm a person. And it just really makes me sad that I can come here day in and day out, you know, regardless of how I feel or what elements I have, in order to provide a service, yes, which then does provide me with an income so that I'm not living on the street. But I also feel like when surrounding cities or healthcare workers are making more than me, it makes me feel like, yeah, I want to leave. But I've been here since 2008. I love all my fellow employees. I love what I do. I love the positions that I work for. But it just, I don't think it's fair. I really don't. And I know life isn't meant to be fair, but at a certain point, you start to feel like you don't matter. And I don't want to feel like that anymore. I really don't. And I hope that you guys recognize what we do provide to the hospital. Because we're not just employee members. We really do provide a service.
30 seconds.
Thank you very much.
Thank you very much. Thank you, Janelle. We appreciate all of your comments. At this point, we're moving on in our agenda. If you feel like you want to stay for the rest of the meeting, we're anxious to have you. If you feel like you could leave, we'll invite you to do that. It doesn't work. You're certainly welcome to stay for the rest of the agenda. We appreciated your remarks tonight. Thank you very much.
Thank you.
Thank you.
At this point, we're moving to written communications. Cheryl, are there any written communications?
Yes, a written communication was received by email from Mabel Lamb of CNA, and I have provided it to the board.
Thank you, Cheryl, very much. At this point, we're moving on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda.
I'd just like to clarify one item on the consent calendar, and that's item B. I just want the board, it is in the memo, but I just want to make sure the board is aware that they are actually approving a total amount of $6,988,047.95 for the total amount of the lease-to-own striker beds and gurneys. So I just want to make sure that that's clear.
Thank you, Kimberly. Does anyone on the board wish to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar, item A through C?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar, items A through C.
Second?
If they need a second.
No, it was from
I'm
Jacob.
sorry,
Yes.
Jacob, I didn't hear you. So we have a motion and a second. Cheryl, if you take the roll on that.
Yes. Director Stewart,
Aye.
Director Nicholson,
Aye?
Director Wallace, Director Yee,
Aye.
Director Epen.
Aye.
Thank you, that motion passes. We now have a presentation to, Kimberly, if you could introduce that for us.
Yes, it's my pleasure to introduce Roy Coloma. He has been a nurse for 15 years and is currently a staff nurse 3 PIC nurse at Washington Hospital. And he is a board-certified medical, surgical, and vascular access nurse. He has been involved in shared governance, education, quality improvement projects, and evidence-based practice projects at Washington. And this evening, he's going to talk about an important project that he's been involved in.
Hello, let me just share my screen here. Okay, hi, I'm presenting preventing central line associated bloodstream infections by monitoring chlorhexidine bath compliance. So what is a central line associated bloodstream infection, or CLABC? According to the CDC, it is laboratory confirmed hospital acquired infection where a central line catheter is in place for more than 2 calendar days prior to a positive culture and is also in place the day of or day prior to a culture. It's reported to the National Health and Safety Network, or NHSN, the National Database of Nursing Quality Indicators, and is deemed a nurse-sensitive indicator by the American Nurses Association and National Quality Forum, in which a decrease in infections is related to an increase in the quality of nursing care. So the burden of CLABC, there was a 7% rate increase from 2020 to 2021 in the US, and rates continue to be higher than pre-pandemic. The Agency for Healthcare Research and Quality estimated about $48,000 in additional costs for CLABC and estimated an annual impact of about 84,000 to 200,000 preventable infections to about 10,000 to 25,000 preventable deaths and $1.7 to $21.4 billion in avoidable costs. So how does WHHS address CLABC? We do this by aligning our strategic initiatives to drive continuous improvement in patient safety and aligning that with operational priority to prevent hospital-acquired infections and aligning that with our unit goals to maintain 0 CLABC incidents in the fiscal year of 2023. So just to go through a little bit of our history of how we got to where we are today. So back in 2017, we worked with materials management to collaborate with them to help develop a customized central venous catheter dressing kit, which was a special kit designed specifically with pockets for the nurses to help them standardize the maintenance process. In January and February of 2018, our CLABC report dissemination was done through shared governance to help share to unit-based councils and down to the unit huddles to help staff and units know where they stood as far as CLABC. And we developed a skill validation for our central venous catheter dressing changes for quality control. So fiscal year 2018, our SIR standard infection ratio was 1.752. The SIRs given to us by the NHSN, the National Health and Safety Network, basically an SIR above 1 indicates more infections than predicted by the NHSN, and conversely, an SIR less than 1 means that you have less infections than predicted. So November 2018, we rolled out the customized central venous catheter kit, and we also implemented a peer-to-peer buddy system with the nurses during for our just and change audits for quality control. We also updated our CLABC bundle in January of 2019, which is an informational sheet, which included insertion and maintenance practices for the nurses, and we use that as an educational tool. So fiscal year 2019, our SIR improved by a little bit to 1.437. So we knew that there was some work to do still. January 2020, after we collaborated with information services, they helped us develop a central line summary audit, which was a database to help track patients with central lines, to help do daily assessments on the necessity of those lines, and to help track compliance of our dressing changes. So fiscal year 2020, our SIR dropped below 1 to 0.879. So we continued our interventions. And fiscal year 2021, our SIR dropped to 1.07. And so for that year, our fiscal year 2022, our goal was to get to less than 0.67. And then we implemented chlorhexidine bathing for our med-surg patients in August of 2021. And October 2021, we began monitoring chlorhexidine bath compliance. So we did a literature review and found significant evidence for chlorhexidine bathing related to decreasing CLABSIs or central line associated bloodstream infections. We asked the question, hospitalized patients, adult patients with central lines, does the intervention of monitoring chlorhexidine bath compliance help reduce the central line associated bloodstream infections standard infection ratio? So our population was the hospitalized patients with central lines unless contraindicated in our critical care, IMC, and medical surgical units. Our interventions included updating our protocol and policy for our nurses to be able to follow, and we re-updated our CLABSI bundle informational flyer, which again covers the insertion and maintenance practices. And we use that tool as an educational tool for our unit in-services, frontline huddles, unit-based councils, and shared governance. We did that through email, and we also included it in our new hire and new graduate orientation and demonstration. So this is an example of the data tracking tool that information services helped us add the chlorhexidine bathing to help monitor compliance. This was our data tracking tool, which we captured daily, monthly, quarterly data for each unit. And then we synthesized that into run tables for our shared governance councils, mainly our quality council, to help report this out to each representative from each unit for performance improvement opportunities. So as far as results, you can see the top graph here displaying our chlorhexidine bath compliance. You can see in quarter ending December 2021, we were only 56%, and through our efforts of reporting out monthly and quarterly basis, we were able to get it up to about 92% quarter ending 2023. We had a goal of 95%, so we still have some work to do. However, you can see its effect on our overall house-wide infection rate for CLABSI number and CLABSI SAR. We have been 0 for the past 4 quarters. So performance outcomes, this graph depicts our fight for CLABSI over the years and our dedication to patient safety. So our fiscal year 2008, you can see our CLABSI house-wide SIR number was at 1.752. And then once we implemented the CHG auditing in fiscal year 2021, in which our SIR was 1.075, we had a goal to get to less than 0.67 for fiscal year 2022, and we were able to reach 0.35. And our goal for our fiscal year 2023 was to get less than 0.35, and we surpassed our goal and have gotten it down to 0. And we have been CLABSI free for about 446 days in counting. So in conclusion, monitoring chlorhexidine bathing compliance helped to decrease house-wide central line associated bloodstream infections, standard infection ratio, and interprofessional teamwork with our nursing leadership, physicians, pharmacists, materials management, information services. and our frontline staff have played a vital role in the success of this project. And I'd like to thank you for your time, and I'll take any questions if you have any.
Thank you very much. Boy, that's very, very encouraging information, exciting information, as a matter of fact. And we really appreciate all the efforts that have gone into bringing those numbers down. What a wonderful report that is.
It's really been significant and really shows the focus that the whole team has.
You know, my hat's off to you, Roy, and your team for, number one, being able to discern what a possible intervention to make an improvement would be, but also implementing that intervention very effectively, and then just beautiful, amazing results. You know, the central line infections can be very severe, very difficult to deal with, and just be able to reduce the number is such a remarkable benefit for our patient population. So you found the magic wand, the silver bullet, you know, keep working at it.
Yeah.
And just, I guess the only question is, what's next?
How do we maintain it? I know, we're working on that.
Yeah, and I do want to recognize that Roy was actually a presenter over at a conference over at Stanford University in terms of the results. So he's been, thank you very much for all that you've done.
Yeah, thank you for the opportunity. Appreciate it.
Now move on to our reports. First of all, we'll hear from our medical staff report. Dr. Mark Soleil, our chief of medical staff. Dr. Soleil.
Good evening, everybody. All right, we have 595 total staff members at the hospital, and 340 of those are active. So that's a little summary of our medical staff census. In terms of my report, I'll remind everybody about the Top Hat that's coming up on October 14th, and we're all very excited about that and hoping we'll have a good turnout. Epic recently changed from what used to be something called Hyperdrive to Hyperspace. I don't know all the technical aspects of it, but basically it is now a web-based application instead of being on the hard drive of the hospital itself, which I understand allows more flexibility with updates and additions. It changed the user interface slightly, some of the user preferences, but I think everybody has adapted to it quite well. I also want to say that we have a leadership training coming up in conflict resolution on September 13th for several of the leaders in the medical staff, including existing leaders and some that are up and coming. And we'll keep you updated on how that goes, but that should be very helpful, I think, to a lot of people. I think it's going to be one of many in the future of different types of training that we will engage in. And this is a collaborative effort between the hospital administration and the medical staff in terms of setting it up and sharing the cost for these types of training sessions. I think finally, the only other thing I want to mention is that we have a new service line for urology that's going to be coming up, a procedure called aquablation. It is a machine similar to a TURP, or the resection, that uses a robotically controlled arm through the cystoscope that uses a high-powered water jet to resect the prostate tissue. And it is a great machine that I think is going to be probably the standard of treatment very soon. The advantages of it are multifold. One of them is the fact that it could handle any size prostate pretty much. A TURP that's done manually has been the gold standard for many decades and does a great job, but is limited to prostate sizes of up to about 80 grams, maybe 100 grams at the most. At that point, the resection time gets to be too long. There's more blood loss. With this one, you could handle much larger prostates, and because the robotic arm is so much faster. It also seems to have better continence rates, less chance of incontinence, and it preserves ejaculation even after resection, which loss of ejaculation is very common after a TURP. So those are the advantages of this procedure, and we're very excited about setting it up in the near future. Any questions about that?
Sounds exciting.
Get in line now.
Thank you, Dr. Soya.
You're welcome. That's my report.
Personally, I'm very excited about the education item. I think that's a very, very nice step.
Thanks.
Work with other physicians in training and working towards leadership and all those kinds of things.
Yeah.
Very, very encouraging. Thank you for doing it.
You're welcome.
Now ready for our service league report, Sheila Vijay. Good evening. Sheila, we need you to hit the mute.
Unmute. There you go.
Can you hear me now?
Yeah.
Yes.
I'll start with good evening again to all of you, to all the board. Warm greetings from all the volunteers. As usual, our volunteers have been diligently engaged over the past month. During the month of July, 224 Service League volunteers collectively devoted an impressive total of 2884. That's 2,884 hours to the hospital's endeavors. In follow-up to the question from last month's board meeting about volunteer numbers, I just want to give you all a summary of statistics from before and after the pandemic. When our hospital was closed to the volunteers in March of 2020, we had 588 active volunteers. That's 588. The numbers declined during the pandemic, but since then, we have seen a steady growth in Service League membership. As of last month, in July 2023, we have 516 active volunteers. So after the pandemic, our adult volunteer recruitment continues to be a challenge, but we continue to orient and onboard volunteers at a good pace. So I'm hoping the numbers will go up as we get more and more comfortable coming back. Now on to some fun stuff that I did last month. I think you'll all enjoy this one. I bring to you my experience following a four-legged volunteer. And I'm not sure if his picture is going to go up. Cheryl, are you going to put his picture up, Bentley's picture up? Oh, perfect. Thank you. Meet Bentley. He's a Labrador who has been a volunteer since June of 2021. Along with his human partner, Ken Carlson, Bentley is a beloved member of the WOOF therapy team. Bentley's mere presence has a remarkable ability to uplift spirits, reduce anxiety, and spread joy among patients. Ken and Bentley share a special bond, working together to bring comfort and smiles to those they visit. With Bentley's soulful eyes and wagging tail and Ken's attentive nature, they create a positive atmosphere wherever they go. On the day that I accompanied the team, I noticed that whenever Bentley and Ken stepped into a patient room, the atmosphere transformed. Patients' face lit up with joy and their burdens momentarily lifted. Ken recounts one visit in particular that stood out for him, and he says, "One day, Bentley and I visited an elderly patient who was experiencing a persistent problem with high blood pressure. The patient offered a weak smile as Bentley and I walked in. The bedside nurse monitoring the vitals noted that the patient's blood pressure was improving due to Bentley's presence. We stayed for a few minutes before proceeding to pursue more smiles. I'm so proud of Bentley and the difference that he makes." Bentley has his own business card, which is what you're looking at on the screen right now, that features his charming face. These cards are distributed to patients and employees they encounter, reminding them of the joy and comfort they experienced during his visit. It also has a little information on him, and if you cannot read the screen, I'll just read it out very quickly. It says, "Bentley loves playing with his toys, naps, and hanging out with his girlfriend, Gracie." Well, Bentley did lose his girlfriend last year. She passed away. He was a little sad, just a side information, but he's okay now since I saw him. Bentley and Kent's service reminds us that a kind gesture and a wagging tail can brighten even the darkest day. Currently, we have 7 wolf therapy dogs in our program, and we always have room for more. And that's a huge hint to everybody listening to me. And that's the end of my presentation. Thank you, Cheryl, for showing that. Please let me know if you have any questions.
Are there any questions from the board?
Thank you. I told you it will bring a smile to your face, and it did. Thank you, everyone.
Thank you, Sheila. Actually, I have to tell you, I smiled when you mentioned the number of volunteers. I know that's not quite up to what it was prior to the pandemic, but certainly that's a great number.
Yes, we've really been working hard at increasing those numbers, and I think we will reach that number very soon, at least the pre-pandemic number.
We appreciate your hard work on it. I'm sure that's a challenge.
Thank you, Dr. Stewart.
Thank you very much. So now move on to our quality report given by Mary Bolron, our Chief Quality Officer.
Hey, good evening. Thank you for having me here tonight. I am going to be going over our quality dashboard for quarter ending June of 2023. This is also the final quarter that closes out our fiscal year. So at the end of each area, I'll give you a little bit of insight to kind of summarize how the year went. Overall, this quarter was very successful for infection prevention and nursing sensitive indicators. We do continue to have some struggles with readmissions, which I'll discuss later. Starting off with our infection prevention indicators, very happy to report another consecutive quarter with 0 infections in the blood with MRSA, a bacteria that's very difficult to treat with antibiotics. And this metric is for patients that it's identified in their blood 72 hours after admission. So again, less than expected, a little bit less than expected. Our next slide is our catheter-associated urinary tract infections, otherwise known as CAUTI. This has been something in the fiscal year that's been a challenge for us. As you can see, it sort of goes up and down. In our last quarter prior to this one, we had 3. This is probably where the frontline team and infection prevention are really partnering the most on looking and drilling down on these CAUTI cases. And they've spent a lot of time doing work on them. And I think some of that's definitely been reflected in this closing quarter where we did have 0 CAUTIs. We really want to work again to continue to show improvements with those in this quarter that we're currently in, focusing on making sure our catheters are only in place to patients that meet for medical necessity of needing a urinary catheter, and that when they do, that we're maintaining it well. So I was really happy to see 0 for this quarter. And then central line associated bloodstream infections, I think it was great because we heard a lot in the opening education session about the great success that we've had with CLABSI. I won't belabor the point since I know you guys had a whole presentation on it tonight, other than to say congratulations to the nursing team, the medical staff who supports us in making sure that we only have lines in place when absolutely necessary. And of course, it's a nursing sensitive indicator because nurses maintain these lines every single day throughout the organization. And there is no doubt that this is an outcome measure that says that that is being done very well in the hospital. And then our surgical site infections, colon surgeries can be tricky and complex and put you at high risk for getting an infection. And again, another outcome measure where we've continued to go on for an extended period of time with 0 colon surgeries that become infected. This is something that the federal government monitors and publicly reports, and we continue to be able to sustain that great outcome. And then moving into our abdominal hysterectomy, surgical site infections, also same thing, consecutive months and quarters without having this surgical site area get infected. And this is also publicly reported and required on a federal and state level. And I think we're doing a great job with this. And it's really reflective of a multidisciplinary team, right down to how your OR is cleaned and turned over to even, of course, the practices of the surgeon and the staff that they work with. So it's great work on their part. C. diff is an infection in the colon that can be very difficult to treat. We have had some challenges in the past, but we are definitely for the pretty much the first half of at least 2022 all the way up to now really sustained very low C. diff rates. As you can see, this quarter we did only have 2. For a hospital of our size and type, the CDC expects closer to 8 infections. And this has been sustained efforts for everybody really working together, making sure that when patients are in the hospital, that we're very careful with the antibiotics we give them. And we maintain very good stewardship here with our antibiotics usage, and testing patients appropriately, isolating patients who do have C. diff so that it doesn't spread amongst healthcare workers. Cleaning the rooms is really important. C. diff lives on surface areas for a very long time. And so that whole team working together has really proven good results with C. diff. Hand hygiene is an initiative that we collaborate with in quality and with the patient safety team. And it's an area that we will always have to continue to work hard in. As you know, by all of us in the healthcare system washing our hands, that is the single most effective way to break the chain of infection and to make sure that we do not spread infection. So currently we were at an 86% rate. We obviously strive for something higher. Obviously our goal here is that everybody would be washing our hands, but the World Health Organization obviously recognizes that that is a challenge. That's why their benchmark is at 70%. So we are above the benchmark for that. We're about 4% less for what Joint Commission expects. During our Joint Commission survey, we did get a lot of positive feedback about hand hygiene. We didn't have any citations for it, which was great. But again, we're always striving for continuous improvement on this because it has such an impact to our patients. And 86%, well, it's good, is not a goal. And so we will continue to work on that by having a lot of auditors down there doing education, listening to the frontline staff about what things prevent them from washing their hands, such as interruptions, availability of sanitizer, et cetera. All those things we always are continuing to look at and make improvements on. So as a closeout for our hospital-associated infections, just this slide is really meant to give you a glimpse of how did this look for this fiscal year that we just completed. And we met 4 out of our 7 HAI goals. And as you can see by the 4 green areas that I've mentioned already, as I said, County was our biggest challenge of the year. And again, we'll continue to work on that, and happy to report that our closing quarter did have 0 county infections. And then moving into our nursing sensitive indicators that are not infection control related. We're starting off with looking at our injuries when patients fall out of bed unexpectedly. We have stayed below the benchmark for excessive period of time, including this quarter, only having our rate be at 0.19. The easier way to think of this is really reflects 3 falls, 2 of which were elderly patients and they had minor injuries. And then we did have one younger patient in his 60s that fell. It was not actually identified as a fall risk early on. It was a very unexpected fall. But overall, again, seeing far less falls than are expected for a hospital of our size and type. Hospital-acquired pressure ulcers, otherwise known as bed sores, doing incredibly well in this area. This is the 4th quarter in a row where we have not had any pressure ulcers identified. This is something that we do by, we have a team of people who are specialized in learning how to identify pressure ulcers, and they go through and they do a point prevalence study and randomly check on patients. And again, you can see 4 quarters without identifying any pressure ulcers, far less than the benchmark. So to close out with the pressure ulcers, very good. We obviously made that goal, and we've also reached our goal for falls with injury. And I would really like to point out that this is a lot of hard work to accomplish this. I mean, when patients are in bed and eating poorly and need a lot of assistance and help, our nursing staff is clearly getting in there, moving the patients, making sure they're on the right mattress, and doing everything we can to prevent pressure ulcers, which is great to see it at 0. And the same with falls. having the patients close to the nursing station when we need them, making sure they always have their call lights, passing, no matter what your job is in the hospital, if you work here and you pass and there's a call light on, there is an expectation that you go and check on the patient. All of that creates a safe environment. And these are two measures of patient safety that we achieved. And again, congrats to the team that works on the front line to accomplish this. Readmission rates, this is, again, in quality, our biggest challenge area right now. It is one of the hospital priorities we're going to be working on in this new fiscal year and continuing to assess what's working out there in the nation for hospitals to be able to reduce readmissions. Do we need to look at our bundle, update it, all of these sort of things we're looking at, because each area in this next set of slides does not meet benchmark except for our procedures. So starting off with AMI, otherwise known as a heart attack, we did have 3 patients come back in the quarter out of 17 patients. These patients were ill, one with a kidney disease, and the other ones had respiratory and cardiovascular problems. They were managed appropriately. It appears at discharge. They were not discharged too early. They were expected to stay an average of 3 days in this group, and they did. But again, we're looking at each one of these cases to always identify areas for improvement. And then pneumonia is also, as you can tell, this is their second quarter of going up in the wrong direction. The CMS expects your pneumonia rate of readmission to be about 14.8%. This quarter, we were at 21.2, which reflects 7 out of 33 patients coming back. Well, pneumonia is and can be complex. We still want to do everything we can to make sure that these patients are supported out in the community and have what they need from their medical staff team that takes care of them after discharge, and make sure that they're getting their medications, they're getting to their appointments. These are things that we've identified with this particular population of pneumonia as being issues. Especially medication management came up a lot in this quarter. And so our transitional care team is looking at ways that we can make sure that patients do get their prescriptions, and if they're not able to get to them, what can we do to help support them? And we do have a lot of community partnerships that that are great about that we're using these cases to learn from and work on. Heart failure, this is the biggest challenge area out of them all. We had 16 patients come back out of 70, and that put us at a 22.9 readmission rate, definitely above what CMS expects, which is 21.3. In looking at these cases, the majority of these patients were over 80 years old, which means that they're typically more complex to manage their chronic illness. We did have a couple patients that actually passed away when they came back. I've mentioned this before, and I continue to mention this. If a patient shows up at this hospital and they need to be in acute care, then they obviously stay in there admitted. That's an absolute value and philosophy that we will always follow. And so there is, though, always opportunity for improvement. You don't want to expose patients to an acute care environment if it isn't medically necessary. So those type of patients we look at in these 16, and there were a few where if we had looked at more about working with the skilled nursing facilities in these cases, because a lot of these patients left and went to skilled nursing facilities, how can we partner with them and talk about what we can do to make sure that patients don't have to come back to the hospital after being at a skilled nursing facility. And one of the things that we've done over those last quarters, we've met with our high quality networks that are skilled nursing facilities, and we're partnering with them on having improved communication when a patient starts to show more heart failure symptoms, and it seems like, they're getting a little bit more symptomatic. What can we do to help them there so that they do not have to go through a transport and come through the ED, et cetera? Again, if they need that, absolutely. But there were a couple cases in here that we did have some lessons learned on, and we'll be working further with the transitional care team on those. With COPD, we had 4 out of 16 patients. That puts us at a 25% readmission rate over what's expected by CMS, which is 19.8, so basically 20%. And with these, it's the same thing. We had, of these 4 patients, they were elderly, complex care. COPD is an advanced chronic illness, obviously, requires a lot of day-to-day management. transitional care is also focusing on this group and looking at ways that we can keep patients comfortable, make sure they have their meds, get their transport, and working really closely with their primary care team after they've been discharged. And then for our procedures, we've done well in these. So when patients come in for a coronary artery bypass graft, otherwise known as a CABG, they stay for the average expected length of stay. We've been able to manage those patients well, working closely with the surgical team and the intensivist group, et cetera. And we've had some good success on this. We did have, as you can see, the prayer quarter is a little bit of a jump. The numbers are small though, so but it still is great that we did not have any patients readmitted this quarter, putting us at a 0% readmission rate. CMS goal is 11.9%. And then moving into our knee and hip replacements, same thing here, second quarter without having any patients readmitted. That was out of 10 patients that are strictly Medicare patients that this is our definition for these patients is defined by the CMS hospital readmissions reduction plan and program. So that's why the number is smaller. We did do more CABGs than that, but great to report that none of those patients had to come back to the hospital. And then, as I mentioned before, the majority of our patients are actually patients that have procedures like hips and knees over the quarter and don't have to stay for very long. They have an outpatient surgery, and we've always had shorter lengths of stay here for those patients. And we want to be able to show you the actual volume of the patients that we manage to we replace hips and knees with. So aside from what the CMS readmissions program definition is, we just add in this slide so you can get a real sense of the fact that we had 526 knees and hips done in this quarter, and only one patient was readmitted. That puts us a very low readmission rate of 0.2. Expected even for outpatient surgery is about 4%. This is really reflective of the team planning these elective surgeries very well, setting up the home health, the PT support, the occupational therapy support, really communicating, working with how we with the patients and their family members to make sure that everybody understands and is prepared for the surgery. And when that kind of planning is in place, it's great to see outcomes such as this. Again, just to show you our readmissions annualized, this is a painful slide. We absolutely do recognize this. This is what I mean when I say there's a lot of work to be done. We did only meet 2 of the 7 goals. And heart failure annualized at 20.1%, as you can see. And then, as I mentioned, the knees and hips tend to do very well at a 0.3. We will obviously continue to work on the diseases that I mentioned earlier, and we have set new goals for fiscal year. This is a top priority. We understand that we need to reduce our readmissions while still offering the good quality of care and allowing patients to be admitted, of course, whenever they need to. So we'll have more updates on this. We're revamping our transitional care team and doing some more research on standard interventions, et cetera, with reducing readmission. So I hope to see some decreases in the next quarter that I can share with you. And thank you for giving me the opportunity to report this evening. Any questions?
Thank you, Mary. We appreciate your report. Any questions from the board?
Just a comment, Mary, when the patients are hospitalized, we have a unique opportunity for education.
Yeah.
Both not only for the patient, but also for the family members. And especially with chronic diseases like COPD and especially heart failure, education is one of the keys to helping improve self-management at home to reduce readmission. So let's think a bit more as far as what we can do as far as educating patients and family to help reduce. I mean, these are tough problems. These are sick patients. I know we're disappointed with our numbers, but we're close on most of them.
Yeah.
I think education can go a long way to help help get us over that hump we have ahead of us.
No, I agree, Dr. Nicholson. I appreciate your commentary, as I know you're very familiar with these patient populations. And you're absolutely correct that there is evidence-based practice that shows that when you go face-to-face in front of the patient that is high or even moderate to high to very high risk for readmissions, that you can establish that relationship with them because they met you in the hospital. Then when you're calling them in 7 days, they know who you are, and you do have an opportunity there for sure. It is one of our focus areas for this fiscal year. We're working and we have some scripting, but I really do want to get the transitional care team in front of these, especially moderate to high risk patients. Very high typically comes back no matter what you do, but the majority of the patients sit in moderate to high risk. And so focusing education there is absolutely a priority, and we appreciate that feedback, and I'll share that with the transitional care team. We'll make that a priority.
Thank you, Mary.
Mary, I have a question. What about language barriers? When you're doing bedside education, the patient may understand, but the caregiver may not, or vice versa.
Yeah, correct. So language barriers, cognitive barriers are especially another issue, especially if the family members are not at the bedside. There's a couple things we do. We are very strict with any form of translation, and if they are going to the bedside, they should be using an actual translator if the patient can hear, so that we aren't doing, or interpreter, I should be saying, actually, sorry. And so that area is a little bit easier, and the discharge paperwork does come in multiple languages, but the cognitive barrier is very challenging. And you know how difficult it is when patients are in the hospital. You really need to, because so much is going on and there's so much stimulus and they're in pain and they're anxious, and everybody coming in all the time telling you different new information, that we have to repeat that information throughout the hospital stay as much as possible. Make sure they leave with it in writing and repeat it again before they leave, and then make sure they get a call when they're at home and there's a follow-up plan. All of those pieces have to come together because, as you say, anytime, even in a language barrier or cognitive barrier or whatever, you run the risk of losing that information. And I think the answer is you really have to have repetitive, ongoing education, repetitive, ongoing communication, because it's such a stressful time being in a hospital. It's hard to retain everything people tell you.
Thank you again, Mary.
Thank you. Thank you.
We're ready now for our finance report from Tom.
Thank you. I'll be reporting on the operating indicators for June 2023. Inpatient average daily census was 153, above the budget of 145.2. The combined average daily census of 163 was above the budget of 156.4 by 4.2%. Discharges of 876 were above the budget of 789 by 87, or 11%. Patient days at 4607 were above the budget by 250 days, or 5.7%. Outpatient observation equivalent days at 281 were below the budget of 336 by 55 days, or 16.4%. And having it below the budget is a positive here, as a reminder. Average length of stay of 5.4, which was below the budget of 5.52, or 12 basis points. This was also lower than the June 22 average length of stay of 6. There were 9 discharges, 1 COVID, 8 non-COVID, with lengths of stay greater than 30 days, ranging from 33 to 54 days. If we excluded these outliers, the average length of stay was 4.87. Still in-house at the end of the month, we had 6 patients with length of stays over 30 days, ranging from 32 to 84. The long-stay patient has pneumonia and is on a trach. CMI for June was 1.488, which was below the budget by 11 basis points, or 7%. Deliveries for June of 124 were above the budget by 8. Total surgeries in June of 385 were above the budget by 17, or 4.6%. Cath lab cases for June at 150 were below the budget by 78, or 34%. And as the board has heard before, we are down 2 physicians in the cath lab. Non-emergency outpatient visits of 8649 were below the budget by 272, or 3%. And emergency room visits of 4683 were above the budget by 140. Moving on to surgical and cath lab indicators. Joint replacement surgical cases were above the budget by 19, 170 versus a budget of 151. Neurosurgical cases were below budget by 4, 25 of 29. Cardiac surgical cases were off budget by 8. We performed 8 and 16 were budgeted. All other surgical cases combined were above budget by 10, or 5.8%. In the cath lab, cases for June were 150, off 78, as we mentioned earlier, and the inpatient cases were 76, when a budget of 44, were 44 below the budget of 120. And then cath lab outpatient cases at 74 were 34 below the budget of 108. Additional operating indicators on productivity. Productive FTEs were above the budget by 36.9, or 2.7% at 1408.1. Non-productive FTEs were above the budget by 39.2, or 21.7% at 219.7. Total FTEs of 1627 were above the budget by 76.1. Total FTEs per adjusted occupied bed were 6.36, higher than the budget of 6.32 by 0.6%. Total FTEs of 1627.8 were above the flex budget based on volume of 1596.9, or 30.9 FTEs. Addressing total deductions, the gross revenue of $174.677 million for June was below budget by 14.8, or 7.8%. Inpatient gross revenue of 104.9 was below budget by 7.2. Outpatient gross revenue of 69.8 was below budget by 9.9 million, or 9.9%. In June, radiation oncology had 3.6 million in net outpatient revenue that was adjusted out of the hospital's financials to comply with the requirement of GAAP, generally accepted accounting principles. This amount represents 5 months of ROC revenue and is currently reflected in ROC's standalone financial statements, and going forward would be in the JV. You can't report it twice. GAAP provisions require joint ventures to only recognize revenues and expenses in one financial statement, i.e. the ROCs, which is the reason why we're excluding the revenue and expenses from the hospital's financials. Overall, the impact of complying to the GAAP reg is 0. Moving it from one to the other, and the numbers are the same. Preliminary payer mix information for June was not favorable. Was favorable at 71.4 to a budget of 71.6. Reviewing the GASB format of the income statement, patient revenue at 174 million was 7.8% lower than budget, as volumes were lower. Deductions as a percent of revenue at 75.01 were better than the budget of 76.96, and this was driven by payer mix, higher commercial in the month of June. Including other revenue, total operating revenue at $48.8 million was 10.5% higher than the budget. Operating expenses at $67 million were $24.5 million or 57.5% higher than budget. Salaries and wages were 3.7% unfavorable to budget. Employee benefits was unfavorable primarily due to the pension recognition that we talked about during our budget presentation. So we recognized that $20 million at the end of June, and that's now reflected in here. And then supplies were 6.8% unfavorable to budget, and that's primarily due to an inventory adjustment in the pharmacy of $270,000. Now we look at the FASB, and as you know, GASB applies to governments and uses modified accrual accounting, which is a combination of the accrual and cash basis. Government entities typically use the modified accrual as it only recognizes revenue when it is available to spend and expenses when they are due. FASB applies to public-private companies and uses full accrual accounting, which measures the performance and the position of a company based on economic events as they occur. And there is little regard to time and date of cash payment. So when we look at the FASB statement, the total net loss for June is $18.7 million, or negative, 38.4%. Using FASB accounting, this was primarily due, again, to the $20 million pension recognition. And the FASB standard reporting unrealized loss on investments, net interest expense, and GO bonds, property tax revenues are removed, so the net income number is slightly improved over the GASB number.
Nice to have a little improvement.
Yeah.
Oh.
Thank you. All right, so now we're going to review the GASB EBITDA. In fiscal 23, the pension expense true-up of $20 million was recognized. This resulted in higher operating expenses. And so as you'll note on the line called EBITDA, we now show 13.78 negative in actual for the month of June on a budget of a positive 5.85. And year-to-date, our EBITDA is reflected at 33.17 on a budget of 66. If we backed out the pension recognition, that would be 53, not 33. The ongoing pressure from the nationwide shortage of healthcare workers has caused pressure upwards on wages and benefits. And the fact that we provide care in the third highest wages area of the country and the third highest area to live in the country continues to put pressure on salary and wages as we move forward. And that concludes my report.
Thank you, Tom. And we appreciate your information. As difficult as it is.
Yeah.
Appreciate that. We can move on to our operations.
Yeah, so I'm going to present the July 2023 preliminary report. I do just want to say that with the closing of the fiscal year, a lot of these numbers are preliminary, and we're still following up on some open items and some of the budgeted numbers. So I just wanted to let the board know that. So starting with gross revenue of $193.8 million for July was below budget by $12.5 million or 6.1%. but was above the July 2022 by $4 million or 2.1%. The inpatient gross revenue of $106.9 million was below budget by $18.2 million and $10.4 million below July of 2022. Our outpatient gross revenue of $86.9 million was above budget by $5.7 million or 7% and $14.5 million or 20% above July of 2022. I do just, we note, and you can see, we did call out the ROC in here, and we will be bringing at one of our next meetings an addendum to the budget to remove that, given what our discussion that Tom did, and also with PwC for that. So moving on to our key census statistics, the average length of stay of 5.46 was above the budget of 5.21 by 0.21 or 4%. This was lower than the July of 2022 average length of stay of 5.49. In July, there were 10 discharges with length of stay greater than 30 days, and they ranged from 31 to 99. And excluding these outliers, the average length of stay was 4.88. So still in-house at the end of July, we had 3 patients with length of stay over 30 days, ranging from 32 to 60. So I think that's the first time we've had only 3 of the long length of stay in-house. So I know that has been something we've been continuing to focus on. However, our outpatient observation equivalent days went up, and they were at 352, which was above budget of 266 by 86 days, or 32.3%. And above July of 2022 by 65 days. Our inpatient daily census of 152.3 was below the budget of 159.6 by 7.3 and below July of 2022 average daily census of 160.1. The combined average daily census of 163.7 was below the budget of 168.2 by 4.5 and 5.7 below the July of 2022 average daily census. And that's the combined that includes the outpatient observation equivalent days. So looking at our discharges trends, our discharges of 848 were below the budget of 943 by 95 or 10.1%. July 2023 discharges were 9 or 1.1% below of July of 2022. And basically the unfavorable variance was in discharges was driven largely by medical cases. Looking at patient days, as the discharges are lower than expected, resulting in patient days of 4,722. This is a below budget by 226 or 4.6%, and patient days were 241 below July of 2022. And really we saw was concentrated a great deal in the ICU and also some in the IMC. Moving on to the surgical trend, our total surgeries in July of 460 were above budget by 5 or 1.1%, and surgeries were 44 above July of 2022. Inpatient surgeries at 191 were below the budget by 13 and 12 below July of 2022. And outpatient surgeries at 269 were above the budget by 18 and 56 above July of 2022. I do want to then go on to the surgical activity broken down. I do want to just note that you'll see that we are calling out endoscopy cases now, just to note those, since is important. And so we were above the budget by 18 for endoscopy cases, and they were 29 above July of 2022. But going back up to the joint replacement surgical cases, they were above the budget by 6 or 3.9%, and 22 above July of 2022. We were down in neurosurgical cases. They were below budget by 12, and they were 7 below July of 2022. We did have one of our neurosurgeons that was out for a great deal of that month. Our cardiac surgical cases were consistent with budget, right on budget at 12, and they were 4 above July of 2022. All other surgical cases combined were below the budget by 7 and were 4 below July of 2022. Moving on to our cath lab trend, cath lab cases for July at 149 were 32 below, or 17.7% below the budget of 181, and 31 below July of 2022. Our inpatient cases at 91 were 1 above the budget of 90 and 3 below July of 2022. So pretty much right on. Our outpatient cases of 58 were 33 below the budget of 91 and 28 below 2022. And as we've talked about, we are bringing on new physicians that will be starting at the end of August, beginning of September, and then in October too. In terms of the breakdown with the cath lab activity, you can see it was really focused on more of the cardiac cases this month, in terms of seeing that they were below budget by 23 and were 10 below July of 2022. We did have some physicians that were out during the month of July. On non-vascular interventional radiology cases, they were below the budget by 3 and were 11 below July of 2022. Peripheral vascular cases were lower than budget by 7 and 12 lower than the July of 2022. Our neuro IR cases were busy this month, and they were above budget by 1 and 2 above July of 2022. We did see a number of thrombectomy cases. Moving on to deliveries, it was a slower month in deliveries. We do go up and down, as you can see. They were at 108, and that were below the budget by 33 and 30 below July of 2022. Moving on to our non-ER outpatient trend, our non-emergency outpatient visits of 8,242 were below the budget by 6.5% and below July of 2022 by 144.5%. They were below budget were mainly focused in 2 areas, and that was the lab and also diagnostic imaging, and were the 2 areas. So, and then again, some of the ROC visits will be also pulled out. Moving on to our emergency room visits, they were below budget. They came in at 4,883. They were below budget by 6.8% or 356, but were 84 above the prior year. So as you can see, we did budget higher than in the past, but they've continued to be, sort of what we've seen in the past for July. So I think that number seems reasonable from that. Moving on to the gross revenue recap, surgical cases were higher than budget, by 1.1%, and you can see that, and driven by endoscopy cases, which have a lower revenue. In addition, neurosurgical cases were below the budget, which have a higher revenue per case, and as a result, the revenue was below budget by $277,000 or 0.7% for surgical services. Our room and board were below budget by $1.3 million or 3.5%. Patient days and observation days combined were 3.1% lower than budget. Again, with deliveries being below budget by 33, revenue was below budget by $856 or 21.9%. Emergency visits were below budget by 356 or 6.8%, but we saw more of the sort of intermediate level visits in the emergency room were higher than we budgeted, so revenue was above budget by $131,000 or 1%. And then lastly, our cath lab cases were below budget, as we mentioned, by 32, but revenue was below by 3.7 or 31.4% lower than budget. We are looking at the charge capture process to make sure we've captured all of the charges for this month. So we're following up on that. And then ancillary revenue was below the budget by $6.5 million or 6.4%, driven by the lower inpatient activity. Moving on to the preliminary payer mix, government-sponsored patient revenue made up 71.9% of total gross revenue. This was higher than the budget of 71.7% and lower than the prior year's percentage of 74.2%. HMO was 2.3% of gross revenue, which was consistent with the budget of 2.3% and higher than the prior year's percentage of 2.1% of gross revenue. Our PPO was 23.5% of gross revenue, which was lower than the budget of 24.6%, but was higher than the prior year's percentage of 22.7%. So the payer mix was the PPO payer mix was 24.8% in June of 2023. Private pay was 2.3%, so we did see that higher than the budget of 1.4%. And higher than the prior year percentage of 1% of gross revenue. There was a total of $1.2 million in charges from out of the country, and we had one account that was over $500,000 in charges that posted in July.
What happens with the shift between Medicare and Medicare?
I know, we saw that.
We don't see that.
It is, and so, I think we're following up on that because there hasn't been anything specific in terms of any changes with that. So if anything, we've been, I think seeing more Alameda Alliance patients, so.
Mm-hmm.
So as I said, I think we need to kind of watch that to see.
Understand it,
Yeah,
Mhm.
I agree. That's the lowest we've seen it
Yeah.
for a while. Looking at our preliminary productivity indicators, productive FTEs were below budget by 43.1 or 3% at 1,401.2. Non-productive FTEs were above budget by 26.7 or 12.6% at 237.9 FTEs. As you can see, we had a number of people that were out on ETO, and so total FTEs of 1,639.1 were below the budget by 16.4 or 1.6%. Our total FTEs per adjusted occupied bed of 5.94 was lower than the budget of 6.29 by 6% or 0.35, and lower than the prior year of 6.18 by 3.9 or 0.2%, 4%. So as I said, we did better in terms of that. We had a number of people out on ETO. Moving on to the other preliminary outpatient statistics. Basically, the Whitmith clinic visits were below budget in July by 508 or 3.3% at 14,768, but they were 2.3% above July of 2022. Basically, we were 7.1% below in primary care, and this was mainly due to we had one physician that was on a leave of absence, but our specialist visits were above budget for the month. Looking at the Development Corporation outpatient visits of 1,712 were below budget by 37 or 20.3% for July, but 12.7% above July of 2022. The main driver really in terms of this is the rehab center. We were down, unfortunately, a therapist had left. However, I was told today we signed on a new therapist that is joining the team. So it has been a challenge in terms of staffing on our outpatient rehab. And this just shows the ROC visits that we will be taking out for the next month. Moving on to the day's financial statistics and charity, looking at the day's cash on hand. We did see a drop in the days cash on hand, a decrease of 11 days. And really this was due, the majority of it was the semi-annual revenue bond debt service payment of close to $12 million that we needed to do. So that accounted for approximately 8 of those days. We also had the month end on a Monday, so we didn't have those additional expenses coming in. So it was a challenging month, and we are following up in terms of watching the days cash on hand. Also saw the days in accounts receivable in July were 58.1. This was 0.9 days higher than the prior month, but 6.3 days lower than July of 2022. There were $375,000 in charity care adjustments in July of 2023. In this month, there were 3 accounts with write-offs exceeding $50,000, totaling about close to $295,000, which constituted about 78% of the total write-off. So those are the results. As I said, we do have some areas we're still following up on for July with the beginning of the budget year.
Thank you. We're ready for the calendar.
All right, I'm going to start with one of my favorites, which is Employee of the Month, and this is for August of 2023, and it's Zubida Ramya, and she is a certified nurse assistant on 4 West. I just want to talk a little bit about Zubida. Her kindness, respect, and compassion are part of our patient-first ethic and part of the excellent care provided by the staff on 4 West. The care that nurses provide is enhanced by certified nurse assistants, otherwise known as CNAs. They interact with the patient in many ways, including assisting with meals, helping patients get to the shower, adjusting bedding to enhance comfort, and generally adding an extra layer of attention and care. When Zubida came to the United States from Ethiopia 8 years ago, she had a desire to work in a way that would provide care for people who need help. She pursued a 2-year CNA certificate, and after working in an assisted living facility, she applied to Washington Hospital. She joined the Washington family in 2018. Nurses on 3 West, she was with the nurses on 3 West and currently on 4 West, have received many compliments on her excellent work. One charge nurse noted, even during a particularly busy schedule, Zubida is always smiling, always professional, and always makes the time to offer help where needed. Patients comment on truly how Zubida seems to care about their comfort and their care. In addition to her excellent patient care, she shows respect for her coworkers with her positive attitude, willingness to be flexible with her schedule, and always keeping the charge nurse aware of her breaks or other times she needs to be off the floor. Zubida is quick to note how much she enjoys and appreciates her work. Making people happy and providing comfort is important to me, she says. When not in the hospital, she enjoys spending time with her family. She lives in Fremont, where her 2 sons graduated from American High School, and her elder son currently attends UCLA. So she's very excited when we came to award her it. She's truly deserving. All right, now I want to go to the calendar and talk a little bit about some of our past health promotion and community outreach events. And wanting to start with, in terms of looking at, I think we've talked about this for a couple of months here in terms of the Fremont Concert Series, and we've been at the Central Park Performance Pavilion at Lake Elizabeth for the summer concerts in the park. And you can see all of the number of blood pressure checks that we have been doing, and we've also been passing out a lot of information about many of our services. July 16th, we were at Mariachi in the Park Festival in the Shirley Sisk Grove, and we did 56 free blood pressure screenings there. So we're doing a lot of work in terms of looking at blood pressure in the community. July 21st, our WIA, our employee organization, collected 4 bags of clothing, undergarments, and backpacks for the Clean Start mobile health unit that they've been needing additional clothing. So we were happy employees have donated much to different organizations in the community. Moving on to, let's see, in July 26th, we hosted Simply the Best. It was basically a thank you for all of our staff and our physicians and volunteers for all the hard work everyone put in for our Joint Commission. So we're very excited. We had some of the dessert trucks there for all 3 shifts. Moving on to July, also on July 26th, Dr. Mustafa, interventional cardiologist with the Medical Foundation, presented atrial fibrillation symptoms and treatment options on Facebook Live and YouTube, and had 75 live views, and 380 people viewed it later. On July 29th, we held and really hosted this in collaboration with many other community organizations, the Road to Wellness Family Health Fair. I know many people were there. We saw almost probably about 1,000 attendees, and we had, you can see, 35 informational booths. We did 73 free blood pressure screens, checks, and then 137 free glucose and cholesterol checks. So, and we also had different vehicles with the fire and the ambulance and the police, and so it was very successful. I know I've heard a lot of great compliments about it. Also then, I just want to note that we've also, our food and nutritional services has been doing donations to the Daily Bowl Food organization, and it's a collection of excess food that's delivered to students experiencing food insecurity at Ohlone College, and also to our senior center in Union City. So this collaboration has really been, with this community organization, has really been a benefit to many. So I just want to you can see some of the pictures from the different events. This is such a concert in the park. Next is the Simply the Best, and then that's the that's the Joint Commission celebration, and then next we have the Road to Wellness Family Health Fair. And then moving on to upcoming health promotion and community outreach events, we have one more on August 10th, the Fremont Summer Concert Series. August 12th, we will be at the Bay Area Community Health Ohana Health Fair. On August 14th, Ellie Gruber, one of our clinical dietitians, will be talking at Acacia Creek on nutrition for healthy aging. Also, very much, we're looking forward to August 15th. We're one of the presenting sponsors for the Welcome Teacher Day. And we will be providing carnation to elementary school students to give to their teacher. And we're collaborating with Dirk Lorenz on this. So we'll be doing it in Washington West parking lot. Then on August 16th, Grace Ching, our clinical dietitian, and Anna Corona, also a clinical dietitian, will be doing a heart-healthy cooking made easy on Facebook Live and YouTube. Moving on, we'll be present on August 9th at the Federation of Indo-American Festival of the Globe. August 29th, Christy Caracappa, our Health Insurance Information Coordinator, will be doing an information session on Medicare, what you need to know, both in person in Anderson Auditorium and on Facebook Live. August 31st, Dr. Seema Sehgal, our psychiatrist, will be doing talking at the Niles Rotary Club about understanding anxiety and depression. And lastly, on September 7th, Elisa Curry will be presenting Staying Active as You Age at Acacia Creek, and she's our coordinator of rehab clinical program. So we are busy ending out the summer. And then lastly, I know Dr. Soleil mentioned it, but one more plug. On October 14th is our 37th annual Top Hat Gala, and we're very excited. This is really returning to our old traditions of years past. We will have a garden cocktail reception. We'll have an elegant 3-course sit-down meal that is served with a very fun, lively dinner show and more. So we're looking forward to that, and all the proceeds will be going to the UCSF Washington Cancer Center.
Thank you very much.
Yes.
We're all looking forward to the top end.
We are, very much.
It'll be a very, very nice event.
Yes.
We're looking past COVID at this point.
Exactly.
And moving to a wonderful event that we've enjoyed.
In the past, it will be the same format as we've done.
Exactly.
Yep.
Thank you very, very much. At this point, we have several action items waiting to consider. We have item A, consideration of resolution 1254, a memorandum of understanding between Washington Hospital and Local 6.
Yeah, we've been in negotiations with Local 6, and for their new contract, there are 65 members, and they represent radiology technicians, cath lab technicians, sonographers, ultrasound technicians, and CT technicians. And I'm pleased to say that we've reached a tentative agreement on a new 3-year term, which was ratified by Local 6 membership on August 3rd, 2023. The recommendation is for the District Board of Directors to approve the agreement. We've outlined the terms in terms of the 3-year contract, and we feel it's a fair contract to move forward with.
Thank you. Can you make a motion on that?
Yes, item A, Mr. President, in accordance with district law, policies, and procedures, I move for the adoption of resolution number 1254, whereby the Board of Directors approve the key terms of a tentative agreement to be incorporated into a new memorandum of understanding by and between the designated representative of Washington Hospital, that being the Chief Executive Officer, and the ILWU Local 6, a recognized majority representative under the terms of Board Resolution 331A.
We have a motion and a second.
Dr. Stewart, you want to ask if there's any public?
You know, Paul, I appreciate you. And, one of these days, I'm going to remember that. I apologize. Are there any comments from the public on that item? Hearing none, Cheryl, take the vote.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace. Director Yee.
Aye.
Director Epen.
Aye.
Thank you. That motion passes. Now, tonight, we have 2 separate action items regarding the potential issuance of revenue bonds and general obligation bonds by the district. Representatives from our bond counsel firm, Peter Wells, Diane Walworth, Nixon Peabody LLP, and our financial advisor, Kaufman Hall Jeffs, Sharback are present and available to answer any questions regarding these items. We appreciate all of you being present. We appreciate your help and work on these items. They're very complex issues, and we appreciate all of your help. Item 7B on the agenda, Resolution 1255, entitled Resolution of the Board of Directors of the Washington Township Healthcare District approving the issuance and sale of and determining to proceed with the negotiated sale of certain revenue bonds of the district in an aggregate principal amount not to exceed $40 million, approving the execution and delivery of a supplemental indenture, a continuing disclosure agreement, a preliminary official statement, and certain other actions related thereto. Approval by a 4/5 majority of the members of the board is required in order to proceed with the issuance of said bonds. At this time, I would open the floor to questions from the members of the board. Are there any questions regarding this resolution?
No questions.
Hearing none. Paul? At this point, I would ask if there are any members of the public who would like to comment. Also hearing none. May I have a motion?
Yes, item B, Mr. President, I move for approval of resolution number 1255.
I have a motion and a second. At this point, I'll call for a roll call vote.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Wallace? Director Yee?
Aye.
Director Epen?
Aye.
Motion passes. Thank you very much. Item 7C on the agenda, resolution number 1256, entitled Resolution of the Board of Directors of Washington Township Healthcare District authorizing the issuance and determining to proceed with negotiated sale of certain general obligation bonds of the district in an aggregate principal amount not to exceed $125 million, and approving certain other matters relating to the bonds. Approval of a majority of the members of the board is required in order to proceed with the issuance of said bonds. At this time, I would open the floor to questions from members of the board. Are there any questions regarding this resolution?
No questions.
Shall be no questions. At this point, I would entertain any questions from the public. Also, hearing none. Dr. Nicholson, could you present a motion?
Item C, Mr. President, I move for approval of resolution number 1256. Second?
A motion and a second. At this point, I call for a vote on that item.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Wallace? Director Yee? Director Epen?
Aye.
Thank you very much, Cheryl. That motion passes. I would also like at this time to again thank all those who have attended the meeting tonight. Lisa Wells, Thea Walworth, Nixon Peabody, and Catherine Hall, Jeff Sarbeck. Thank you very much for your attendance tonight. It's always helpful to have you. And we haven't had any questions for you, but it's nice to have you here available. Thank you very much.
Thanks for hanging out all night.
We're happy to be here. Thank you.
Thank you.
Thank you. Talk about the difference.
Yeah.
Okay. We have no further action items. We've reached the bottom of our agenda. And at this point, I would like to adjourn this meeting. Thank you all for your attendance. Thank you all for being here.
Thank you.